Guys, so we are looking at ophthalmology. In this, let us look at the next set of basic MCQs. Okay, very basic, easy only, don't worry. The normal axial length of the eye. What is the normal axial length of the eye? So the normal axial length of the eye is 24 millimeter. This is the answer here. Okay. So let's look at the answer. Answer is 24 millimeter. That's nothing but 2.4 centimeter. So you just in your finger, just measure 2.4 centimeter. So you can feel that this is the eye axial length. Okay. So the next question here is all are parts of anterior segment of the eye except. This is an except question. So in anterior segment of the eye, what and all will you have? So anterior segment you will have cornea, anterior chamber, this is the posterior chamber, iris, lens, all this will be there. So lens will be there, lens is correct only, it will be there. Cornea, yes, it will be there in the anterior segment. None is wrong answer, none should not be there here. Answer is vitreous. Vitreous is behind the lens. So all are parts of the anterior segment of the eye except it will be vitreous. So here you can see vitreous, it is behind the lens. So if we consider lens as the demarcation, so posterior becomes vitreous. So definitely it is not there in the anterior segment. Let us look at the answer here. 3. Okay. Let's move on. Which continues to grow in the lifetime? Here you should know lens will grow lifetime. So you can just remember lens as the answer. Okay. Let's look at the answer here. It should be 3. Lens. Okay. Then let's move on. Thickness of the cornea is measured using. Thickness of the cornea is measured using pachymeter. Okay, let's see pachymeter. So you will measure how thick the cornea is. So what is the cornea, you know, right? So this is the cornea. So they will measure its thickness using pachymeter. So some minimum amount of thickness should be there for doing these kind of laser surgeries, etc., which they do for all this LASIK refractive errors correction. Okay. So what is keratometer? You have seen all this in the previous MCQs. Keratometer for measuring the curvature of the cornea. Okay. Now we saw pachymeter for thickness of the cornea. Okay. So what is the answer? 3. Okay. Let's move on. How is it going, people? Shall we take another 4 questions? In the normal human right eye, the peripheral field of vision is usually least. So they are asking for the least. Okay, least. So just mark here, least they are asking. In the right eye, peripheral vision least on left side. So they are talking about the right eye. It is least on the left side, that is nasally. Or is it least downward, or is it least upward, or is it least on the right side, that is temporally. So when you look nasally, it will be a little less. What do you think? Nasally will be a little less because there is a nose up, and then upward also will be a little less because of your forehead and eyebrow and all that. Then downward, absolutely there is no blocking. Right side also there is no blocking. So it has to be either left or upward. What do you think? So what is the answer? The answer is 3. So upward is the maximum block. So you can say the least will be upward direction. Okay. So upward will be the least peripheral vision. So answer is 3. Okay. Least. In normal human right eye, the peripheral vision, the peripheral field of vision is usually least in the upward direction. It is same for left eye also. Upwards, the peripheral field of vision will be least. Okay. Because your frontal bone is blocking. So look at this. Upwards or superior 50 to 60 degrees. Downwards 75 degree. Nasally 60 degree. Outwards 100 degree. Temporally 100 degree. So here the least is superior upwards. Okay. And the next least will be nasal. Look at this question now. Antero-posterior stability of eyeball is provided by all except. This is an except question. So who is giving stability? Antero-posterior. Is it superior oblique, superior rectus, orbital fat, suspensory ligament of the eyeball? Let's look at the answer directly here. 1. So this ligament is not providing any antero-posterior stability. They are saying superior oblique is providing some stability. Superior rectus also, superior oblique, superior rectus and orbital fat are also giving some stability antero-posteriorly. So the suspensory ligament is providing inferior support. So here you can see suspensory ligament inferiorly. Okay. How many questions did we finish? No idea. Look at this one. Retinal blood vessels are developed from. The retinal blood vessels. Here they are saying blood vessels means they will be from mesoderm. So let's just go with this answer and check. Answer is 2. So basically they are saying blood vessels will be mesoderm only. Okay. So let's go to another question. Image seen by an indirect ophthalmoscope or image seen by indirect ophthalmoscopy is it a real image? Yes, it's a real image. It is inverted. Okay, this is the answer. It is real and inverted. So let's look at the answer. Yeah, real and inverted. This is indirect ophthalmoscopy. They have not actually mentioned clearly in this. Okay. So here the image will be real image, right? Real image is actually always inverted. Okay guys. So here you will get in indirect you will get inverted image. In indirect you will get inverted image which will be real. So what image will you get in indirect ophthalmoscopy? Inverted image. So here the image will also be magnified. Okay, that is the whole point. You want to see it enlarged, right? So here you should say it will be magnified also. So what is the principle of indirect ophthalmoscopy? To make the eye highly myopic, so you will place a convex lens. Okay, you will place a strong convex lens in front of the patient's eye. Okay, so you are placing a strong convex lens in front of the patient's eye and you will make the patient's eye highly myopic. Okay, that is the first thing they are explaining in the principle. Okay, so that the emergent rays from an area of fundus are brought to focus as a real inverted image between the lens and the observer's eye. Okay, so let's look at that now. So in front of the patient's eye they are keeping a strong, very strong convex. Okay, so they are making myopic. So you can see it is kind of focusing before the retina, right? So it is, the patient's eye has become highly myopic now because you have placed a convex lens here. Further, I think let's look at this image. It's more understandable here. So basically what is happening, this is the patient. They have marked here as the patient. Here they have kept a converging lens, that's a convex lens here. So whatever image has to form, it will be highly myopic. It will form before the retina. Somewhere here only it seems to be focusing. Right now there is a examiner here, right, and between him and the lens which you have kept, there will be a inverted real image that is formed. Okay, and it will be magnified also. So you know, to check for retinal detachment and any other peripheral retinal lesions, they will use this. So let's move on to a few more questions, guys. What say, are you liking it? Okay, so we look at a few more questions. Look at this. Corneal endothelial cell count is done by cornea. Where is cornea? Here, the outermost, right? So the cell count in the endothelium. So endothelium means inside. Okay, so the inside part of the cornea. So this part somewhere, the endothelial count you want to know, cell count. So whatever outside you have, that will be the epithelium, but we are talking about endothelium here. So this is the endothelium. So they want to know the cell count in this endothelium. Look at the options here. Specular microscopy, you need a microscope. Keratometry, no, that is for checking the curvature of the cornea. Gonioscopy is to check the angle of the anterior chamber. Slit lamp examination, something else, right? You can examine the fundus with slit lamp. So here, corneal endothelial count, cell count, if you are doing cell count, kind of a giveaway it is, you need a microscope. So they are saying it is a specular microscopy. Let us look at the answer here. Yes, answer is 1, specular microscopy. Basically, with this you can also look at the variation in the cell size, you can cell diameter, the hexagons, decreased hexagon, increased average cell diameter, increased variation in cell size, everything you can find out, okay. If there is a decreased endothelial cell count, basically whatever changes are there in the endothelium, those cells, till the level of cells you can see with this specular microscopy, okay. Next question here, floaters can be seen in following except, this is an except question. So vitreous hemorrhage, if there is hemorrhage in the vitreous, retinal detachment, uveitis, acute congestive glaucoma. Let's understand one by one and see. One option they are telling is in vitreous there will be hemorrhage. Then one more thing they are telling is retinal detachment, the retina gets detached. What else are the options? Acute congestive glaucoma. This kind of sounds to not a cause for floaters. Let's look at the answer here. Yes, answer is 4. So basically in these 3 there can be floaters, but in acute congestive glaucoma there will not be floaters. Let's look at some explanation. So patient is seeing these floaters, so it can happen because of retinal detachment, vitreous hemorrhage, uveitis, these 3 we have already seen. High myopia, okay, they are saying high myopia, posterior vitreous detachment. What is this? Even vitreous will detach, is it? Inflammation of eye, that is uveitis and uveitis. Okay, so these 3 they have given us options, right? So we have marked this as the answer. Acute congestive glaucoma, there will be no floaters, okay. Another question here, periphery of the retina is visualized by. So they are not talking about the whole of retina, they are specifically telling if they want to see the periphery, what will you use? So there are 2 questions with the same kind of statement. The periphery of the retina is visualized with, so you have indirect ophthalmoscopy, direct ophthalmoscopy, contact lens, Goldman's 3 mirror contact lens, Ruby's lens. This we have seen in that slit lamp, right? So contact lens is definitely not the answer. This Ruby we saw in slit lamp, right? Then, so let us look at the answer here. So basically it is not contact lens or any of the things, so it should be either direct or indirect ophthalmoscopy, right? So the actual answer here they are saying is, let's look at the answer, 1, that is indirect binocular ophthalmoscopy, okay. So it is indirect ophthalmoscopy, binocular, okay. So it is indirect ophthalmoscopy is the answer. So indirect ophthalmoscopy, it offers better view of the fundus, okay. So it is better than the direct one, it offers broader overview of the fundus, right. So you can see the fundus as far as to the periphery. So this is what we want, so that is the answer. If it was center part of the retina, you could have said direct ophthalmoscopy. See here they are saying central part, optic disc and fovea, centralis, all that, direct ophthalmoscopy. But if it is peripheral, then you can go for indirect ophthalmoscopy. This is direct ophthalmoscopy and this is indirect ophthalmoscopy, okay. Let's just take a few more questions and close this video. Indocyanin green angiography is the most useful in detecting. It's a green angiography is most useful in detecting. The answer they are saying here is occult choroidal neovascularization, okay. So neovascularization means what? New blood vessels, right? And here what is getting the new blood vessels? Choroid is getting the new blood vessels. So here there can be vision loss. So what is choroid? Do you know choroid? What choroid is? So look at this. So this innermost is retina, outer you have sclera, between these two that orange whatever they are showing, that is the choroid, okay. In age related macular degeneration you would have heard of this term, right? Choroidal neovascularization. For choroid they seem to like this indocyanin green, okay, but for retinal they are saying fluorescein, okay. Fluorescein angiography they prefer for retina. Now look at this question, fluorescent dye for ophthalmological diagnosis is injected in, okay, so they will inject it in antecubital vein. Is this anterior cubital vein? Okay, something anterior to the elbow, okay. True about visual testing in a child, that you are testing visual testing in a child, what will you use? Why would you use a perimetry or keratometry, these don't seem to be right to me. So answer should be within these two. What do you say? Let's see the answer. Answer is 4A and B. That is some acuity and some visual evoked potential, right? Child cannot obviously do perimetry, and keratometry is to measure the curvature of the cornea. So what is visual testing there about for a child? Okay. So answer is A, B. Next. Corneal endothelium is embryologically derived from. So we already saw this cornea, right? This is the cornea. So outside it has the epithelium, inside there is endothelium. They are asking this endothelium from where it comes. Okay, so let us look at the options here. Neural crest, ectoderm, mesoderm, endoderm. So actually the answer here is neural crest. Look at the answer, neural crest, because except the epithelium in the cornea, everything comes from the neural crest. Okay, so corneal epithelium they are saying is a surface ectoderm. Everything else, the stroma, the keratocytes, corneal endothelium, neural crest, they are saying. How's it going, guys? Just let's look at 2-3 more. Okay, coloboma, most common site. Coloboma, what a name. Most common site. Let's look at the answer here. They are saying, what are the options here? Supratemporal, inferonasal, inferotemporal, supronasal. Okay, let's look at the answer here. Answer is 2, inferonasal. What is this thing? Coloboma. Looks like coloboma is some absence of some tissue. Okay. And it could be absence of iris, ciliary, body, choroid, etc. It can even be the absence of lens, coloboma of lens it will be. Okay. So basically they are asking here coloboma most common site. So they are saying it is inferonasal. Okay. Which of the following procedures which of the following procedure does not need dilation of the pupil? So to examine fundus, yes, you need dilation of the pupil. Laser, retinoscopy, yes. So gonioscopy you don't need. So basically you are checking the angle of the anterior chamber. So this is more to treat glaucoma, right? So you don't need to dilate the pupil. So fluorescein angiography, one more question here on this. It is used to identify lesions in all except retina. We use it, that's what we said. So retina will be a correct answer. Lesion in lens, optic nerve, head. Why not? That also you can use, right? So let's look at the answer here. The answer is 2. So you will not use it to identify lesions in the lens. Okay. See, basically lens, cornea, these are avascular structures. So you cannot use any angiography, right? I think this much is enough for now. We have looked at a few basic MCQs for ophthalmology, just the starting chapter. Okay, that's all for now, guys. We will meet you in the next video. Bye bye.